Good afternoon, everyone. I am Ana Diaz-Rue, the Dean of the Dornsife School of Public Health, and I'm delighted to welcome you this afternoon to our second speaker in our Population Health Spotlight series for this year. And as you know, the theme of our series this year is Racism and Health, Evidence and Action. It's a very auspicious day for us to have this talk because, as many of you may have heard, we just announced a wonderful gift from the Dornsifes that will allow us to launch a center on racism and health at our school, and also recruit a couple of faculty in that area. So we are absolutely thrilled and can't wait to get started. Today we have a wonderful speaker joining us, Dr. Rachel Hardeman. Dr. Hardeman is Associate Professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health, where she is also the Blue Cross Endowed Professor of Health and Racial Equity. And Dr. Hardeman's work focuses on reproductive health equity, and in particular, the links between racism and reproductive outcomes. And she does interdisciplinary work that really leverages frameworks of critical race theory and reproductive justice to understand the way in which racism and all its many manifestations at various levels affects the health of Black birthing people and their babies. And in this work, she also engages very actively with a number of community groups and organizations, including as an example, the Roots Community Birth Center, which is one of only 5 Black-owned freestanding birth centers in the United States. She received her training at Xavier University in chemistry and Spanish, which is a great combination, I think, and then received her MPH and her PhD from the University of Minnesota. And I'm sure you'll agree that she has an absolutely wonderful title of her talk today, and so relevant: Stolen Breaths, Exploring Solutions to the Disproportionate Impact of Police Violence and the COVID Pandemic on Black Lives. So thank you so much for joining us today. After Dr. Hardeman's talk, we will be taking questions. Please enter your questions into the Q&A function, and I'll be presenting them to Dr. Hardeman. We'll have some time for questions till about 3:15. So thank you, and thank you so much for joining us.
Thank you so much, Dr. Diaz-Rue. I'm so excited and honored to be here with you and to share some of my work. I'm just going to get my screen shared, and then I'll jump right in. I feel like, okay. Can someone just confirm for me that everything is operating great?
It's perfect.
Thank you. I always get a little sad when I can't see my audience, but I should be used to this by now, given that we've been in this, in this virtual space for months. But again, I'm really, really happy to be here and to share with you. I am going to try to leave my comments to about 45 minutes so that we have plenty of time to have a discussion and some Q&A. I would like to start with just a brief land acknowledgement. The University of Minnesota, Twin Cities, is located on the traditional, ancestral, and contemporary lands of Indigenous people, particularly the Dakota land, which was ceded in the treaties of 1837 and 1851. And I think it's incredibly important to acknowledge this, and that, there's this complex and layered history with the Indigenous communities here in the United States. And this land acknowledgement is just one of the ways that we can begin to educate ourselves and honor that history and lift up the Indigenous folks among us. I'm also coming to you from the land of the Minnesota Paradox, where we are ranked as one of the best places to live in the United States, and often are ranked as sort of having the best health outcomes. But what I'm going to talk about today is the fact that that's not true for all Minnesotans. Many Minnesotans, Black Minnesotans in particular, are very simply fighting to breathe, to take a singular breath. And I want to start my time with you all today by centering us on words that I wrote with my colleagues, Dr. Ria Boyd and Dr. Eduardo Medina, in the New England Journal of Medicine, in our piece called Stolen Breaths. Please, I can't breathe. He was a Black man detained on suspicion of forgery, an alleged offense that was never litigated or even charged, but for which he received an extrajudicial death sentence. Please, I can't breathe. He was only 46 years old. Please, I can't breathe. And he was loved. But despite onlookers' pleas and his own calls of distress, with his face against the pavement, 3 officers on his back and a knee in his neck, he was murdered. Please, I can't breathe. While trained officers and paramedics stood by and a horrified community witnessed, George Floyd was denied the basic rights of due process and the basic dignity of life support. Please, I can't breathe. And in 8 minutes and 46 seconds, with a deadly infectious disease in the backdrop, George Floyd was murdered by the Minneapolis Police Department. And sadly, Mr. Floyd's death was not a new phenomenon for our community from Minnesota, and really nationally. The Star Tribune, our local newspaper, collected the names and stories of everyone who's died after a physical confrontation with law enforcement in our state since January 2000. And what they found is there's been 199 deaths. Nearly 30% of these deaths were Black people. However, Black people only make up 7% of the population in our state. Nationally, we know that American police forces killed 3 people per day in 2019 for a total of 1,100 police killings. And just to put that into context with the rest of the world, in comparison, the Guardian newspaper reported in 2015 that there were a total of 55 fatal police shootings in England and Wales between 1990 and 2014, so over a 24-year period. And in Germany, they reported that only 15 people were shot fatally by German police in 2010 and 2011 combined. A recent study in the National Academies of Science, PNAS, found that police violence is a leading cause of death for young men in the United States. And this graph shows the estimate of lifetime risk of being killed by police use of force, using data spanning from 2013 to 2018. And the researchers here estimate that over the life course, at levels of risk similar to those observed between 2013 and 2018, about 52 of every 100,000 men and boys in the United States will be killed by police use of force. The authors also find that women's lifetime risk of being killed by police is about 20 times lower than men's risk. However, among women and girls, Black women and American Indian or Indigenous women's risk is highest. The authors actually state that they expect between 2.4 and 5.4 Black women and girls to be killed by police over the life course per 100,000 at the current rates. And this face might look familiar to many of you. Breonna Taylor is one of the women representing this statistic. Breonna Taylor deserved to lead a full and healthy life, and yet she was murdered while she slept in her home at the hands of police officers. And though Black women make up 13% of the female population in the United States, they represent 20% of women killed by police and nearly 30% who are killed while unarmed. And I think what we see with respect to women, particularly Black women dying at the hands of police, is this troubling pattern of the killings being justified as the women being caught in the crossfire of something else that was happening. And so I think we have a long ways to go when it comes to thinking about the intersections of race and gender and its impact on police violence. And I'm happy to kind of dig into that more as we go. I also think it's why a reproductive justice lens is incredibly important for the work of public health generally, and certainly with respect to police violence and understanding sort of population health, social determinants, and structural inequity. And for those of you who are unfamiliar, reproductive justice is the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. And for those who, so my work really sits in the space of reproductive health equity and thinking about, birth outcomes and maternal outcomes. But I would argue that reproductive justice is a lens and a framework that can be used outside of just reproductive health outcomes, particularly the part I bolded here, which is that we have a right to live in safe and sustainable communities. And when we are struggling with police violence and we are struggling with a global pandemic, we've lost that right. And for some communities, and Black communities in particular, that right was never actually available to all folks to begin with. So I'm going to share a little bit about my current work and my current research in this space of using this framework of reproductive justice to think about police contact and police violence and its impact on Black communities. And what my work has shown is that in Minnesota, there is, we know that Black birthing people have a higher incidence of preterm birth, so birth before 37 weeks of gestation. What we're seeing in our analyses right now is that police contact, so I'm not even talking yet about police violence or police brutality, but simply living in a community, living in a neighborhood that has where that's policed more frequently, where there's more frequent stops by police, where police are patrolling those areas more frequently, what we're seeing is that there's an increased likelihood or an increased odds of preterm birth happening among birthing people that reside in those neighborhoods. And what we see also, because of the deep history that I'll dig into in just a few minutes, of particularly around racial and residential segregation in the Twin Cities and across our country, really. Many of these neighborhoods are disproportionately Black and therefore disproportionately policed. And then we see that this is one more factor that's leading to these adverse birth outcomes. And my qualitative work has revealed some themes around the struggles of living in communities that have experienced high profile events of police violence. So in the Twin Cities here, we've, there's, as I opened with, there's been 199 deaths, but in the past few years in particular, the deaths of Jamar Clark, Philando Castile, Thurman Blevins, and of course, George Floyd have really put Minnesota and the Twin Cities in the national spotlight when it comes to police violence. And I started this work actually just after Jamar Clark was shot and killed in 2016. And part of it was having conversations with Black women of reproductive age and Black mothers around what the lived experience of living in a community that's experienced this trauma, what that means for both their health and well-being, for how they decide to parent and become mothers or decide not to become mothers. One of the things we were hearing a lot for those who were pregnant was that they didn't want to find out the sex of their baby because the pain of knowing that they were having a boy was too much to bear throughout their pregnancy. We also learned a lot about the worries that Black mothers living in these communities have and carry with them about how they can keep their children safe, feelings of not having control over over their families, and also hoping for something different and something better. I think one of the other interesting things that we find that's not on this slide is that while this is an important and critical element of folks' lives, it doesn't define their lives. So a lot of, what we heard and learned in this work is that, and I think it sort of speaks to the ordinariness of racism in the lives of Black and Brown folks, is that this is one more element that is sort of part of our lives and something that, folks have to just to deal with. And if folks are interested in learning more about that work, I encourage you to check out this piece that came out, I guess, last week or maybe a couple weeks ago now, November 13th, on National Public Radio, where Yuki Noguchi did a beautiful job, I think, of really helping folks to understand the impact of George Floyd's murder on our Minneapolis community, and also tying that to my work and other folks' work in the space of infant and maternal mortality. So if that's not enough to convince you that police violence and police contact are a public health issue, I hope this slide will do the trick. But really, my colleagues and I, this work was led by Dr. Siri Long, who's at Lehigh University, and we, a few years ago in 2017, sought out to frame police brutality and police violence as a public health issue, as a social determinant of health. And this was prior to the APHA declaring law enforcement violence a public health issue, which has now been done. And I think that we have really begun to sort of, as a field, shape and understand and explore police violence and policing as a determinant of health, of population health. But what we argue in this paper is that violent encounters with police have a profound effect on the health, well-being, neighborhoods, life chances, politics, and that certainly it plays a role in sort of maintaining structural inequity between people of color and white people in the United States, and that there's these multiple pathways and how that plays out. Everything from, of course, the fatal injuries and the death of the individual, but sort of the ripple effects through community, and how that really sort of plays out in a variety of different ways, both economically as well as through mental health and stress and things like that. So, going back to George Floyd's murder, I think it's important to recognize and realize that all of that happened and played out in the backdrop of COVID-19, a pandemic, a global pandemic that's disproportionately harming communities of color. And as my colleague, Dr. Boyd states, Dr. Rhea Boyd states, COVID-19 could have harmed anyone. And yet because of racism and its pervasive hold on every institution in America, COVID-19 has been the most devastating and deadly for Black Americans. So I want to share a couple of slides now that kind of help us to set the stage or understand the impact of COVID-19 on Black populations. These slides come from a story that was published in the New York Times a couple of months ago that's based on my colleague, Dr. Elizabeth Wrigley Field's work that's published in the National Academy of Sciences, that's really highlighting sort of racial inequity and COVID mortality among Black populations. And that first piece of it is really understanding that in 2018, white people in the United States died at an age-adjusted rate of 89 per 10,000 people. So COVID-19 has likely caused the biggest jump in white mortality since World War II. And what we know and what we're watching play out before our eyes, certainly right now here in Minnesota, is that many Americans will lose a parent or a grandparent or a brother, a sister, a child, an uncle to this infectious disease. But here's the thing, if Black people were immune to the coronavirus, their mortality rate in 2020 would still probably surpass that of white people. So Dr. Wrigley Field then models back to the start of the 1900s to show that the gap in death rates has existed for Black versus white folks, has existed for essentially as long as we've had the data to be able to collect these this information. So between 1900 and 2015, Black excess deaths totaled 8.8 million. And we have to imagine how COVID will impact this reality even more. So what they show is that if Black people had died at the same age-adjusted rate as white people in 2018, they would have avoided 65,000 premature excess deaths. And that's the equivalent of 3 coach buses filled with Black people crashing and killing them all every day of the year. So the big question is, how did we get here, right? How did we arrive in a reality where a global pandemic is killing people of color at disproportionate rates, while we look on in horror as Black and brown people are losing their lives and their livelihoods at the hands of those who are meant to protect and serve? And, I think to understand that. I don't claim to be a historian, but I do firmly believe that in order to understand population health and health inequities, we have to, we can't take a historical approach to this work. We have to understand the history of how we got here. I am not going to do this history any justice by any means, but I do think it's important to call it out. And so I'll spend a few slides doing that and also doing a quick time check. So, I think to answer these questions, we have to go back 401 years. And I think that for me and the presentations I give, this is the point where folks, if I were in the room with you all, there's folks who would sort of get uncomfortable or start to squirm in their chairs, because what I'm going to ask you and what I'm suggesting you consider is that the data I just presented to you and much more of what we know about health and well-being is deeply embedded in the history of racism in our nation, and that together we have to both understand it and reconcile its connection to contemporary inequities in order to develop the appropriate solutions. And so these pictures depict, 1619, a group when a group of 20 Africans were sold into bondage in Jamestown, Virginia, and the start of Black enslavement throughout our history. And I also think it's important to share these timelines because it's a reminder of how deeply ingrained this history is and all of the ways that white supremacy in particular has taken new shapes and forms in order to maintain and uphold structural racism. So what we know is that Black enslavement has made up 60% of our country's history in Jim Crow. So those state and local laws that enforced racial segregation made up 20% of our history. So that's 80% of our country's history is based on slavery or the legalization of racism and racial segregation. And this history has certainly fundamentally shaped who we are today. And it also speaks to just how much work we have to do to undo the ways in which these ideologies have framed every institution that we work, live, and educate our children in. So just for the sake of clarity and definitions, when I name white supremacy, I'm referring to a culture or an ideology, this ideology that white people and the ideas, thoughts, beliefs, and actions of white people are superior to people of color and their ideas, thoughts, and beliefs and actions. White supremacy culture is artificial, it's socially constructed. It's a socially constructed culture that expresses and justifies and binds together and upholds and frankly perpetuates structural racism in our country. And it's reproduced all over the place in all of our institutions. The longer you swim in a culture, the more invisible it comes. It's indeed the water we swim in. It is, we don't realize it's there because it's just the norm. And I think because of that, we don't realize sort of that dominant frame that shows up in the media. It shows up in the way that we educate our students in public health. It shows up in the way that we frame our research questions. My colleague and I, J. Meg Carbia, we just published a paper in the journal Health Services Research where we talk about sort of the ways that white supremacy has framed the work of health services researchers, right? And the idea that even when we think about our comparison groups, when we're doing our research analysis, we tend to, in health inequities and health disparities research, we tend to have, we tend to be looking at a Black or brown community or population and comparing that to white folks without really thinking about why that is and what the standard or norm really should be and sort of questioning that along the way. So what we have is when police violence, white supremacy culture meets a global pandemic and civil unrest, we have a lot of work to do is what this tells us. I think we're at a point and at a moment in our history where we can either kind of delineate the path forward and do the hard work and sort of dig in, or we can put our blinders back on and sort of return to the status quo. I certainly think that what COVID-19 has shown us with respect to sort of how the healthcare system has innovated and has really shifted to ensure that it is offering and taking care of really sick people is that we have the power to be innovative and to be thoughtful and to be creative. And so, my hope is that we walk away from this talk today with sort of ideas on how to do that in our own spaces and in our own work. So, I think that leads to the question, that I get most often, which is sort of, so if we know about this history and we know that we're struggling with health inequities and we know all these things, like, what do we do about it? And I think that's a huge question. It's not one we're going to be able to fully answer today. But I do want to offer, sort of spend the rest of the time kind of walking through some steps on how we should be thinking about this work. And so I want to start with a piece that I published with my colleagues, Dr. Eduardo Medina and Dr. Katie Casimano in 2016, where, we wrote this in response to Philando Castile being shot and killed by a police officer not far from our offices on the University of Minnesota campus. And we were thinking a lot about sort of what would our message be? What should our message be to our colleagues and to our friends who don't, particularly our clinical and sort of research friends who don't think that perhaps they have a role to play in changing this, right? Who feel like, police officer involved shootings is that other stuff that doesn't have anything to do with me. And so, we wrote this call to action. And the first thing we said is that we have to learn about, understand, and accept the United States racist roots. And in order to do that, we have to explore the origins of racist ideas. So hopefully some of you are familiar with Ibram Kendi's work. His most recent book, How to Be an Anti-Racist, has, I think, been widely read, certainly over the past few months. But his first book, Stamped from the Beginning, which is a really long and sort of, it's a long 800-page read, historical read, but I think it's an incredibly important and compelling book because it lays out the fact that, discriminatory actions wrought by sort of self-interest come first. And then, what he says is that racist ideas are developed to justify them. And then the discriminatory actions and the racist ideas spread. And that this dates back to the 15th century and it's multiplied. And sort of just as I showed you with that timeline, it takes different shapes and forms sort of certainly throughout the colonial era and early slaveholding republic. So one of the examples I always use to sort of illustrate how racist beliefs have become racist actions is the story of James Marion Sims, who I'm sure many of you are familiar with as credited to be sort of the father of modern gynecology. And he took racist beliefs and translated them into racist actions by conducting research on enslaved Black women without anesthesia. And the racist belief sort of at the foundation of his practice was that in addition to their status as enslaved people, that Black women were considered appropriate subjects for his experiments based on the widespread belief that Black people experience less pain than their white counterparts. And so the racist belief of obstetrical hardiness also became this sort of influential racial folklore within medical theory and practice because it harmonized so well with the racial ideology that had already shaped Western thinking about racial differences and allowed for this sort of justification of Black bodies to be used for research. And so this photo, this photo is a photo of, or a drawing, of Anarcha, who was a 17-year-old Black woman, enslaved woman, who was James Marion Sims' primary subject. And he experimented for her for over 4 years, I think close to 30 operations before he declared that he had perfected his methods. And I think it's important to be able to understand this history, certainly now as we grapple with COVID vaccines and, the sort of headlines we keep seeing around Black communities and distrust with respect to COVID vaccinations. And if we don't understand this history and the harm that's been done, we're not going to understand why folks might be hesitant to get a vaccine, for instance. So, now that we've learned a bit about the racist roots of the United States, we also have to learn how racism has shaped the narrative around health disparities and health inequities. And, the COVID example I just shared is certainly one of them. What we see, and there's a really, I think, powerful study that was published in 2016 that helps to sort of give us an understanding of how this plays out. In that 2016 study at the University of Virginia, they found that 50% of white medical students and residents endorsed beliefs like Black people are more hardy, can't feel pain, have thicker skin. So these beliefs, whether they're explicitly stated or implicitly sort of built into the hidden curriculum, are they, however it's happening, and it's sort of permeating the beliefs that our future healthcare workforce is taking with them in their education. And also, what that study found, interestingly, is that the 50% of medical students and medical residents who endorse these false beliefs about race being sort of biological, they also were more likely to score sort of higher on the implicit racial bias or the implicit association test, which measures implicit racial bias. And speaking of implicit bias, I think it's incredibly important to make sure that we understand sort of the link between implicit bias and structural racism. I think as a field in public health and also in medicine, we've gotten fairly comfortable talking about implicit bias and sort of talking about this process of associating stereotypes or attitudes towards groups of people without our conscious awareness, and sort of this idea that it's this automatic bias. It's a social cognitive process, right? That causes people to interact with folks that are different from them in very, sort of specific ways. And while I think that's an incredibly important point, it's insufficient towards the goal of advancing greater equity of opportunity, of experience, and certainly changing the outcomes in health for Black communities. What I would say is that, we have to really be thinking about implicit bias as situated as a part of a larger conversation about how inequities persist and how structural racism is perpetuated. And I think our success in sort of creating health equity or working towards health equity is certainly has to be a part of our willingness to confront the history of structural racism and thinking about how implicit bias fits within that. So how those narratives are sort of contributing to structural racism. And I've used the term structural racism quite a bit already throughout this presentation and have not actually defined it. So I will do that now. I'm just going to check on the time really quickly. So structural racism is the normalization and legitimization of an array of dynamics. So historical, cultural, institutional, interpersonal, that routinely advantage white folks while producing cumulative and chronic adverse outcomes for people of color. I think it's important to understand, whereas implicit bias, we're talking about sort of these interpersonal one-on-one interactions often. When we're talking about structural racism or systemic racism, we're talking about a system of hierarchy, a system of inequity that is characterized by white supremacy and is offering preferential treatment. And again, just like that slide I showed with respect to sort of white supremacy culture, it's a lot of it is the water we swim in. It's so many different ways and shows up in so many different ways. Some of them that we don't even sort of notice along the way. And given that we're in a school of public health, I'm in a school of public health, and I'm assuming most of you on this webinar are as well, I think it's important to think about how we as a field have thought about and produced evidence around structural racism as a fundamental cause of health inequity. And what I found, so in 2018, 2017, I, along with some colleagues, we published a systematic literature review in the journal Public Health Reports, where we looked at the public health literature, the top 250 public health journals from 2002 to 2015. The 50 highest impact journals, not that, we found 250 articles basically, but we were interested in looking to see if institutional racism, structural racism, systemic racism, or a similar term, were named in those articles. And what we found was that between that time period, only 25 articles named structural racism. And we also noted that structural racism was a core concept in only 16 of those 25 articles. And so, I think we have made some strides since then, but we also have a lot of work to do, particularly in sort of understanding our social determinants of health framework, which we hold dear. And we, I think, one of the first things I learned when I started, training in public health is that where we live, work, learn, and play matters for our health, right? We understand that health does not occur in a vacuum, and that instead it's deeply embedded, right, in the conditions in which we, people are born and grow and live and work and age. But I think what we have failed to do really well is to make the link between why that's the case. Why do these social determinants matter for health? And at the root of that, I would suggest is structural racism. So structural racism is certainly going to dictate where someone lives, right? So I'm sure many folks are familiar with sort of redlining and the act of literally drawing, lines on maps to separate those quote unquote hazardous and declining neighborhoods from those that were considered the most desirable or best neighborhoods, and creating those codified patterns of racial segregation that dictated where Black people in particular were able to buy a home and live, right? So redlining is an example of structural racism perpetuated through a policy that then has dictated where someone lives. So the neighborhood context, and when we talk about zip code mattering for someone's health, at the root of that is a structurally racist policy. And so, my hope and my goal, and in the field of public health, is really to make sure that we're making those connections, and also are measuring them and operationalizing how that's playing out in both historically and in contemporary ways. So I also want to talk a bit about how this shows up in healthcare delivery. So I'm trained as a health services researcher, and so a lot of my work, while it's sort of at the population health level, it's also thinking about how do these structural inequities show up in the ways that folks are accessing care or not accessing care. And so I think it's important to sort of understand that piece of it as well. And I'm just going to offer a few examples briefly from my work, and I actually might skip a couple just for the sake of time, because again, I think question and answer time is just as important and valuable. But this work, police brutality and mistrust in medical institutions, was led by, again, my colleague, Dr. Syria Long at Lehigh. And, we were really interested in, understand. So with the understanding that people bring sort of the social context of their lives into the medical encounter, we were curious to look at if police violence or police brutality as a social determinant sort of had any influence on trust or mistrust in medical institutions. And what we find is that, police brutality or having a negative interaction with law enforcement increased mistrust for all racial groups, and particularly for the Black folks in our analyses or in our population. We also have some forthcoming work that shows that for those who report having experienced a negative encounter with police, that it impacts their likelihood of utilization of healthcare services. I think I'll skip over this one and just mention that, again, my work is in the reproductive health equity space. And so thinking about sort of what's happening when folks are accessing care and sort of how racism is playing out in those spaces is incredibly important. And more work is sort of starting to come out in that space. And this is an interesting example from a paper that I published with colleagues back in August, where we were interested in looking at physician-patient racial concordance with physicians and newborns. And so we looked at 1.8 million hospital births in the state of Florida between 1992 and 2015, and found that newborn physician racial concordance is associated with significant improvements in mortality for Black Black babies, for Black infants. And I think the really compelling thing, part of this work is that first, the physician-patient racial concordance literature has always looked at sort of adult interactions, which makes sense, right? And part of what we've seen and what we know about that is that there's a communication piece or a miscommunication that's happening between perhaps a Black patient who's being seen by a white provider. There's some really great work from a group of economists that shows that when Black men have a Black provider, primary care provider, that they're more likely to have all of their sort of preventive care, colonoscopies and things like that done. So in this case, Black newborns, there's no communication piece, right? Because they're infants, they're newborns, but yet we found a pretty significant difference when a Black newborn was cared for by a Black provider. And I think a lot of folks reading this work really struggled with that. With that finding, and this suggestion that perhaps they are doing, as a white provider, that they are, intentionally doing harm to a patient. And that's not at all what we're suggesting or implying in this work. I think, to me, what this tells us is that we have a lot of work to do to examine our institutions and the climate within sort of both our medical education, I would offer in our public health institutions, in our healthcare delivery institutions, to think about how institutional racism is playing out and sort of permeating or sort of hidden and embedded in the ways that we're both interacting with patients and their families, the ways that we're trained or not trained to sort of ask questions or to do the work of caring for patients. And so I think it's a space where we need to really sort of consider digging in a bit further. All right. So then the question is, how do we do that, right? So, and that's a big question. I don't have all the answers. I think while our 2016 New England Journal of Medicine piece that I mentioned and sort of offered a couple of our pieces of our call to action there, we're really about sort of individual level things that clinicians and researchers, public health folks should be doing to think about their role in dismantling structural racism. This piece, Stolen Breaths, where, how I opened this talk, really, and of course we published it just after George Floyd, or wrote it and had it published just after George Floyd was murdered. I think asks us to consider also what we should be doing within our bigger institutions or systems to start to move the needle even further and towards dismantling structural racism. So I'm going to spend a couple of minutes before wrapping up talking about sort of the points that we put forth in this article. And I hope that this will serve as sort of a space to think and be creative and have some reflection and questions around as well. So the first thing we offer is that we have to divest from racial health inequities. Racial health inequities are not signs of a system malfunction. They're the byproduct of healthcare systems functioning as intended. And I would say not just healthcare systems functioning as intended, I think all of our systems, right? And that speaks to sort of the need to understand the historical context of what's happened for centuries in our country to be able to see sort of what we mean by that. And so, certainly that ties to the need to understand that history, but we also can't keep, putting Band-Aids on all of these sort of issues across our systems, and really need to start thinking bigger than that. We also offer that we have to intentionally desegregate the healthcare workforce. And I will be the first to say this is not a new statement. This is not a new call to action. This is not a new ask. We've been talking about desegregating the healthcare workforce, the public health workforce, for a very long time. The Sullivan Report and many others have said this, but yet here we are. Black physicians make up just 5% of the healthcare workforce, but 13% of the population across the United States. One of the things that I think is important to point out that we write about in this piece is that, and that I think is often sort of not the angle that's taken when talking about desegregating the healthcare workforce, is this idea that, healthcare systems are very much, economic engines in large employers in our communities. And so by desegregating the healthcare workforce, I'm not talking about just making sure that there's more Black doctors or more Latino doctors in the system. We're saying that we have to think about desegregation across sort of across all roles within a healthcare system, because extending employment opportunities is certainly going to extend the employer-based insurance pool, which we know is being sort of decimated due to COVID-19. It's going to raise the median wage. It certainly will support the local tax base. So if we look at sort of the historical implications or impact of redlining and, looking at the sort of local tax base in different communities, thinking about desegregation of the healthcare workforce from that lens, I think is incredibly useful and important. And in that ties to countering the gentrification and residential segregation that often we see surrounding sort of major medical centers. And this doesn't even touch on sort of what we're seeing play out in rural communities. I think that's a whole different bucket, or not different, but related bucket of issues that we have to grapple with. And again, each of these has the potential to, each of these things will improve population health in some way. We also state that we must make mastering the health effects of structural racism a professional medical competency. So, just like clinicians have to master, sort of anatomy and physiology or whatever it may be, if we truly believe that structural racism is a fundamental cause of health inequities, we're doing our public health students, we're doing our medical students, we're doing our social work students, and everyone in between a disservice by not ensuring that that they are proficient and have mastered this understanding and can speak about it and can relay that message just as they might any other sort of more medical sort of message that they're or training that they're receiving. And part of that means that we have to mandate and measure equitable outcomes. So just like healthcare systems are required to meet sort of rigorous safety and quality and performance standards for accreditation through JCO or whatever their accrediting body may be, we also need to think about, what's required to meet, what should be required to meet rigorous standards for addressing structural racism and achieving equity and outcomes. And, I would say that, so we frame this for healthcare delivery systems and hospital systems in particular, but certainly we have to be thinking about this, a similar mandate within our schools of public health. And again, both, with the mastering the competency of structural racism and also, thinking about ways to build in a system that is able to measure and sort of create a standard for quality in this space, I think is incredibly important. And then we close by just simply saying, healthcare systems are here to protect and serve, and that is exactly what we should be doing. Healthcare systems play an important role in advocating for patients, and that includes all patients. So victims of state-sanctioned violence. They're also patients who may present with injuries, disabilities, mental health impairments, and all interests, and particularly their interests must be defended. And so I think it's imperative that our systems, if we really, really are going to stand up on our sort of values of equity, taking a clear position about the disproportionate killing of Black people at the hands of police is incredibly important. And not doing so is certainly running counter to the commitment to protect and serve that we believe that systems of health and public health have put forth as their goal and mission, right? So in closing, I want to just share a final quote from our paper, Stolen Breaths, in which we state, in the face of literal gasps, as Black communities bear the physical burdens of centuries of injustice, toxic exposures, racism, and white supremacist violence, too many either do not know what our communities endure or are aware but choose not to act. And so today, I hope that I have inspired you to choose to act. If you haven't already, I'm sure there are many of you who have chosen to act over the past few months, and for that I'm grateful. I think we as a field are in a critical moment where, particularly as we await the new political administration, we're in a critical moment where I think a lot of change can happen as if we continue to sort of keep up the momentum. And so with that, I will close and thank you for your time. I always want to thank my amazing team of collaborators. This is just a few of them, but none of this work would be possible without them. So thank you so much.
Thank you. Thank you so much, Rachel. I can't start my video. Diana, can you check? It's telling me that I can't start my video. Okay. Thank you so much, Rachel. You can hear the virtual applause. This was wonderful. I think the breadth and the clarity and the integration and the call to action is really great to hear. So thank you so much. I'm sure we'll have a lot of questions. We already have some. Folks can enter questions in the question and answer. I'll start. I wish people could read their own questions, but unfortunately the setup we have doesn't allow that. But I have a first question from Barbara Beeler, who says, this has been a spectacular presentation. And she asks, given the importance of the recognition of structural racism and improving public health, how do you see the impact of the AMA's recent decision to stop looking at race as a signal for potential intervention, but to look at the social determinants of health for which most clinicians have no vocabulary or tools to consider?
Yeah, that's such an important question. And for those who are unaware, the AMA recently recognized racism as a public health threat and a public health issue, which is a significant thing for the AMA. And I don't mean that in a disparaging way, but I think the history of the AMA would suggest that this, this is a big deal because there is a deep sort of history and pain with respect to the AMA and its exclusion of Black physicians and physicians of color for a very long time. And I also want to say that because I just have to give credit to the incredible young scholars and medical students who contributed to those efforts at the AMA. I think they've done incredible work to help move this forward. And I think your question though speaks to the need to rethink and reform our medical education curriculum. And I also, again, I think public health is included in that. And, it's certainly the work that we're doing and thinking very deeply about at the University of Minnesota in our School of Public Health, as well as in our medical school, because we are right now doing our students and trainees a disservice by not sort of teaching, the social construction of race in a comprehensive way. So they get some of it right here and there, a lecture on health disparities, but it's not deeply embedded sort of throughout the training, the 4 years of training in medical school, or the 2 years of training in our a Master's of Public Health program. And so, we have a lot of work to do. And I think the fact that the AMA has made this statement, and it has actually really offered some pretty great details, I think, around race as a social construct and what that looks like, is going to help sort of lead that charge in the clinical space. And I would say not even lead that charge, contribute and support that charge, because really, I think that there are some incredible folks that have been leading that charge for quite a while now. And so I think the AMA kind of getting on board is certainly going to propel it forward with more resources and more sort of, I look forward to what's to come there.
Thank you. Here we have another questions. What are your thoughts on reparations, or what kind of solutions do you see for reparations while addressing systemic health disparities?
Oh man,
yeah.
That is such a great question. And I I always like go back and forth on if it's something to like include in these sorts of talks, because I think having the conversation around reparations is an incredibly important and valid one. I don't see full justice being served or achieved without reparations. I am not convinced that we are close to that yet. Not even, I mean, even with a new presidency and a new, administration coming in, I don't think that we're there. Um, and I also think that perhaps what we should be thinking about is not reparations broadly speak, like, sort of widely speak or broadly speaking, but really thinking about what reparations would look like in various areas across across these social determinants or whatever it might be. So I've been thinking a lot about like what would reparations, for instance, in medical education look like? And to me, that means, really, beyond sort of what we refer to as like these pipeline programs of like getting, physicians of color through the process of applying to medical school. But also, it's not just that, but it's making sure that it's paid for, that no loans have been taken out in that process, whether it's undergrad, during a post-bac, or during medical school. It means making sure that people have the tools and the resources at their disposal to be effective and to achieve what they want, and what their goal is, and however, whatever form that might take, without having to worry about, how to pay their bills, or how to build intergenerational wealth. I mean, even the folks who have been successful in, sort of a pipeline medical education program, they still have loans to pay, right? And they still, and so that there's that loss of opportunity, for instance, to build intergenerational wealth. So I think, we need to be getting creative about what reparations can look like across sort of all of these different sectors, and proceed accordingly. But I fear that we're not there yet,
Mhm.
unfortunately.
I think one really important aspect, which I think we're seeing a little bit of a change, is also this recognition of history, right? Because this conversation about reparation is about history, right? So this
Right.
profound power of history operating intergenerational, which I think is something that, sort of the naive approach to health disparities, not only is it very biomedical, but also it just ignores that whole history. And so even just opening up to recognize the power of that, right?
Indeed.
Yeah, so important. Another question here. Here's another easy one. Lots of easy questions. Well, how has the work that you have done on surfacing the disparity in policing trends and police brutality, has that translated into any changes in policies in local police departments, or how has that been perceived? Maybe have you had any interactions around that, reactions to it?
Yeah, that's a great question. So I'll start with the perceived part first, because not I mean, in short, it prior, I guess I started this work well before the George Floyd incident, at least 4 years prior to that, and it was not perceived very well at all. I have horror stories of like sitting in meetings where, with like local police and public health folks, and thinking that we were sort of all on the same page of like health and well-being, and and it did not end well. And I think, um, I've learned a lot from those interactions, certainly, and around sort of how to frame my work and sort of what the end goal is, and how to, the language to use sort of in those interactions. I think that now, uh, there is a more openness and willingness to have those conversations, which is important. And we have a lot of local leaders, and city council and county level leaders who are really sort of getting in front of, and really leading this charge. And so I have, the opportunity now to, to sort of put the empirical evidence in front of folks, right, in a way that, without having to sort of do the other level setting and table setting as I was having to do 4 years ago, which I think is really, I mean, speaks to sort of how we've moved forward. But I think the reason we've moved forward is because we've witnessed some really terrible stuff, right? And some really horrifying and painful things as a community. And so, but I think, and I think we're right now in the Twin Cities having conversations about what does it mean to defund the police, and what does that look like, and how do we shift funding, and how do we still, and what does public safety look like? And so my goal right now, and sort of what gets me sort of excited, is to reimagine public safety and community safety, and actually help community articulate what that means for them. Because for me and for the work that I do, if we don't start in community, and if we don't start with conversations with those who are most impacted, then our efforts are futile.
We also have a lot of compliments. Thank you for this illuminating presentation. You're an inspiration. So many compliments. And another question says you used a slide that showed a picture of a Trump rally, and it begs the question, what difference do you see in a Biden administration's response to structural racism in healthcare? Yeah. What do you think? This is hard too, but do you have any thoughts on what things might change?
I have been thinking about this a lot because I'm writing something about it right now. And so both, I don't want to scoop myself, but I also, and a lot of it is like, I still like don't know what, and I think a lot of us don't know, right, what that looks like. I don't want to assume that like we've hit the promised land, because in reality, like the bar is so low right now that like anything is better, which is my personal belief. But also like anything being better doesn't mean that that's that's good enough, right? And so I think, I think the response, as I've watched the response, the Biden administration's response to like the COVID-19 and building that task force, and I'm incredibly excited about the potential. I think that there's been a lot of intentionality in sort of who Biden and Harris are selecting to lead, which is really important and really, I think that has to be, part. At the forefront. But honestly, like it's politics are politics, right? And so I also feel like it's a hard question to answer without knowing what's going to happen in Georgia too. But I do think that we're having more attention paid to structural racism than in sort of the political sphere than we have in a very long time, which is exciting.
Thank you.
Yeah.
Let me see if there are any other, perhaps in closing, if I may, I'd like to ask you for your advice. As I mentioned earlier at the beginning, we've just received this wonderful gift to launch a Center on Racism and Health at our school, and Sherelle Barber, who I think is, and who's I know is listening, is chairing the planning effort for us, and we have several other faculty members involved. And do you have any, off the top of your head, any, we have this opportunity here, and the planning group, Sherelle and the team, have many great ideas that we'll be moving forward with. But do you have any, what would be the top things that you think a new center should try to grapple with? Do you have any thoughts?
Yeah. My initial thoughts are Dr. Barber is incredible and has done incredible work. And so the fact that she is involved in sort of envisioning this is, that's like the best of the best, right? But I also think though, and at least what I hope for any center that is focused on racism and health is that both the leadership model allows for sort of I think we get stuck in this sort of academic space of like, this is a, academic research center, and it doesn't have to be, right? Or we can change what an academic research center means and looks like, and that there's opportunities for leadership for folks that don't have 10 bajillion letters behind their names, right? And that, there's so many different, I think, and unique models for co-leadership where there's a community member, meaning a community, meaning someone outside of sort of the ivory tower, right? That and also that in the construction and sort of the conceptualization of the center itself, that that there are many conversations along the way with the people who are closest to the effects and the pain of racism. Because without that, I think, we live in this danger of sort of replicating the status quo, which, we've seen is not, as it doesn't work, right?
Thank you. That's very, very good
Yeah,
advice. Thank you very much.
yeah, my pleasure.
Well, thank you
And
so much.
congratulations, that's a really exciting.
Yeah. Yeah, we're so happy. So, and thank you so much, Rachel, for spending the time with us. I'm sure you're being asked to give a lot of talks, and we really appreciate it. And I know everyone listening will join me in thanking you. We're very appreciative that you took the time and really enjoyed the remarks that you've shared with us. So thanks so much, and hope we can keep in touch.
Thank you. Yes, definitely.
Sure.
Thanks, everyone.
Thank you.
Bye.
Bye.